Morning, Craig.
Morning.
Good morning.
Craig, just want to let you know that we're broadcasting like we had
I
talked
saw
about
that.
earlier.
I saw that when I jumped in. I was like, yay.
Compliance.
I mean, I like the halo effect I'm getting from my fluorescent lights, but I'm not sure if it's justified.
I'm monitoring the Teams link. Some people are still joining the Teams link, so I'm gonna join Teams real quick and tell them to go to the Zoom.
So we have 15 members now, right? What are we up to?
Oh, participating entities
Yeah.
should be, is it 17?
Uh,
Michelle,
thought
do
it
you
was
know
seven,
your heads? I think we had
I thought it
14.
was 17.
17? Okay, so
That's what I thought.
quorum's 9.
Okay. Just it's all is it always just over 50%? Is that right? Or
50% plus 1.
okay. Wow. We're getting big, so big.
I know.
Yeah. Morning, everyone. Morning.
Morning.
Craig, you hear me all right?
Yes, sir.
Good deal.
Oh,
Lindy, do you have a camera?
Yep. One
Okay.
second.
Wayne. Hello, sir. How are you? Been a long time.
Trying to get it to put, but they never did allow me to put my name in.
That's all right. We know who you are.
You right click on your view or your name, you can rename yourself.
I got it there.
Okay.
There's 11. Still got people coming in. I think this is going to be our largest meeting in a while, so which is great.
Some of them are probably coming over from Zoom. I just got educated on that. Mike, can you hear me?
We can hear you, Mayor. We just can't see you.
Oh, well, let me work on that. That's probably not something you want to see. Good morning, Mike, and thank you, by the way. I haven't got to talk to you.
You're welcome.
I do appreciate that.
Mr. Chairman, I have 9 members present.
Indeed, I had around 11. Let's see who's here.
Okay.
Let's see.
Well, I've been
I'm
on
here.
2 virtual calls at the same time this morning.
Okay,
So
this one. So 1. My screen keeps moving. Maybe it's 10. 1, 2. So the members I have is myself with Villa Hills. I have Mayor Adams with Carrollton. I've got Harry Annis with the Boone Water. I got Wayne Loneker with East Pendleton Water. Got Chris Corbo with the Ad. Lori Sparks with Ludlow. Lindy Jenkins. Oh, please help me, Lindy. I'm sorry. I always have you in Covington in my head, and I know that's not right.
Bellevue.
Bellevue. Okay, thank you. Paul Herringer, Independent Fire, Terry, Carrollton Utilities, and Tony with Park Hills. So I agree we have quorum. So we'll go ahead and call the meeting to order. We have quorum. Next item is approval of the agenda. And in the email I sent out, I am asking that a 4th bullet point item under number 6 be added, calling banking transition. And I will be happy to accept that motion.
So moved.
Second.
Awesome.
Right. Harry, Terry. All in favor, please say aye.
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 Okay.
Any opposed? All right. Next item on the agenda is approval of the minutes.
So move.
Mayor
Second.
Adams, second Harry. Any discussion or changes? Hearing none, all in favor, please say aye.
Aye.
Aye. Any opposed? Great. Next on the agenda is the financial report.
Host disabled participant screen sharing. Chris, can you allow me to share my screen?
Yeah, hang on for 1 second. Should be able to. Give me a second here. I do have IT on the call, so hang on for 1 second.
Okay.
Give me 1 second, please.
Sure. Oh, okay. So this should be good to go. Let me try again. There we go. Okay, can everybody see the spreadsheet?
Yes.
Okay. So this financial report is a full report for the year we just ended. So fiscal year 2024. And let's see, it's hard to see it all on one screen. Okay, so the attachment point, which is the maximum amount of claims per your stop loss contract that you would have had to pay this year if you had a worst case scenario year, which you did not, was $5.2 million. You ended the year with $2.8 million in in-network claims, $1.2 million in out-of-network claims. And a lot of these are not truly out-of-network in the traditional sense. They're just reference-based pricing claims that were not at contracted facilities. And then $834,000 in pharmacy claims. Your fixed costs were approximately $1.2 million. So your total plan cost before any stop loss reimbursements was about $6.1 million. You had so far about $250,000 in specific reimbursements, and there's another $27,000 in specific reimbursements pending. No aggregate reimbursements. And so after reimbursements, the plan costs were about $5.9 million. You collected premiums of about $5.4 million. So we ended the year with a deficit of about $467,000. And then you ran at about 87% of your attachment points, which about 75% is pretty standard. So you had kind of a heavy claims year. Over on the right-hand side of the page, we've added in pharmacy rebates, which were about $101,000. We now get interest because of the changes in the banking, which Craig will be discussing. About $6,100 so far. PCORI fees last year were about $1,500. That's a little ACA tax that we still have to pay. And HRA claims, those are for specialty drugs that we couldn't get sourced elsewhere. We're about $64,000. When you add in last year's reserve of about $2.2 million, we ended the year this year with about $1.77 million in reserves. So any questions?
I'm sure when we go through the year-end report, we'll get an idea of what precipitated the 467,000. But as far as the 1.77 million reserve, where does that land us as far as our recommended reserves?
Can I check on that while Amber's doing the MedBen report, Mr. Chairman?
Yes.
Okay, I'll do that.
Anybody else have any other questions?
Only question I had is how did that reserve compare to last year? But that's, for me, a little bit of a moot point. If we just find out where we should be, like you just asked, that's probably the most important. So.
Yep. All right. I'll stop sharing.
Any other questions or anything on the financial report for now? All right. Next item on the agenda would be the MedBend end of year review.
All right. Good morning. Let me get this pulled up. Oh, it does say, Chris, that it disabled share on my side.
Should be good now.
Okay,
Hang on for a second. Sorry.
you're fine. Oh, it looks good now. Oh, wait, let me make this. Okay, can everybody see this?
Yes.
Okay, perfect. Okay, so this is going to be the 2023-2024 year-end review. I'll go through kind of page by page, but we won't hit on every number figure. If you have any questions, just let me know. Okay, we go to page 1 here. We're going to touch base on average number of employees, some of your aggregate information, your per employee per year plan paid information, some of the things that Lisa just touched base on. First of all, it does look, and we're going to compare your far right column to the one right next to it, just as we could get a comparison this year versus last year. Do you see that we're down? Average members has gone down from 675 to about 631. Employees, it's down a tad bit too. You do have some medical claims, obviously, that have gone up. You were about 3.5 last year. You're about 4.1 this year. Your pharmacy, however, is down a bit, which is great. We always want to continue to work on that. You do have your stop loss reimbursements, like Lisa had touched base on, which again does help the plan. It does look though with your medical and your RX net, you are up about 9% overall from your net total from your previous year. And we'll touch base on how these figures may be high claimants and stuff on the next couple of pages. Large claims, if you hop down right here, large claims last year 1.3, this year about 1.9 as far as your large claimants percent of your total claims. That's about 40% of your total claims. Oh. And then if you look at your total net claims and your fixed cost, you're going to see that you're up about 17%. You're going to notice that your increase total cost from plan per employee per year last year has increased a tad bit on your fixed and your net claims. I am going to go down to your next page here and we'll get into that a little bit more. Does anyone have any questions on that? Okay. Okay, so if we look at this page right here, you're gonna, we're just gonna touch base again on, like we did on the first page, your average employees, average members. Your change, obviously you're down a little bit as far as members. You do have your medical aggregate plan paid is 19.56%. Your pharmacy, you're running at about 779,000, whereas last year at 804. Again, that's down. And we're going to do your per member per month plan paid is up about 27.86%. You will see that on that estimated reimbursements this year, you do have a little bit there in your numbers. I'm sorry, my other screen just went out. Pharmacy is down. Well, current period is $102.82 for your pharmacy per member per month. Last year was $99.20. Any questions on this page? All right, let's scroll down to your next one. This is your health plan snapshot. This is going to give us a little idea as our benchmark, how you ran last year as opposed to this year. You will notice on your inpatient, you did have 26 admissions. 8 of them were surgical. And you will see that has caused you to go up a little bit. You're at 105. So if you look at the blue line, this is your current year. The brownish color was last year, and then your benchmark. So you are up a little bit as far as your inpatient. You were at $96 last year per employee per month, but actually you're well below our benchmark of $155. You will notice, as well as your outpatient, you've got a 23% increase in your outpatient surgeries, a 35% increase in colonoscopies, and you had 11% increase in mammograms, plus chemo for one of these members was performed on your outpatient basis. You are going to see a jump in that as well. And if you look at this number right here, you're going to see your current period is $320.54. Last year was $295. I'm sorry, last year was $228. You are above our benchmark a little bit, but again, that is due to chemo for your outpatient. For a member is hitting your outpatient. Office visits, you just had a 1% increase overall in office visits, but you did have a 30% increase in mental health office visits. Again, I think we've been seeing this kind of across the board. There are some mental health visits do seem to be up, which of course we always encourage that. And any questions on this? Okay, move down. Okay, this is going to tell you your healthcare, your medical trends here. Your average age is 32 years old on your plan. If you've got fewer claimants, but more claims that have been processed. So you're going to see, again, this is why you've got an increase of your total claims. I'm just going to give you your average family size on your plan. This year is 2, last year was 1.9. You are going to see your total paid was $4,160, as last year was $3,479. So that is an increase of about 20%. Average claims cost is $396. Last year you were at $353, below the benchmark of $437, although you are up again a tad bit there. And keep in mind though, that is below our benchmark. Okay, any questions on that one? Okay. Next page here, we're just gonna, this just tells you enrollment, dependent, how many employees, spouse. There was a drop in every category of enrollment. So employee, spouse, dependents, excuse me. And this just gives you a breakdown of where we're seeing the most claims. Obviously, we're seeing your employees have the most claims on your plan, then dependents or spouses and then dependents. Okay. I'm going to move down to page 7. It's going to give you your top hospital providers. You're going to have St. E's, obviously, is going to be your top provider. Also, keep in mind that St. E's is broken down by the tax ID number that they use. So there are different locations, obviously, and we want our members to go to there. So you've got about 350 claims at St. E's. About 148 members have gone there. This makes up 38.46% of your total plan paid. Children's being the second, you've got 210 claims there, about 52 members. Also, you've got the St. E's for Fort Thomas, Christ Hospital, you've got 75 claims, about 28 members. And then it looks like your Baptist, LaGrange and the Louisville is right in line there. This will compare, if you go to your next page, it's going to be your previous periods. You can compare. Again, you're at St. E's for your previous, last year, your Baptist was your second, Children's was your third, and University of Kentucky. You had 7 claims there, 3 members. And if you go down, you do have Norton Children's, St. Matthews there. That was also being utilized too. Okay. Next page is going to give us our office visit utilization. You're going to see you had about 2,500 routine visits. We always encourage those. Your biggest increase was your mental health, which is up by 30%. So you're going to see, this will give you kind of your office visits by month. You'll see like a drop maybe in the summer and then spikes back up towards fall, people trying to get their wellness exams and stuff. So that's, you'll see those numbers across the board jump like that. So office visits cost about $211, about 6% off our benchmark as far as cost, which is allowed per your visit. Any questions?
Amber, I have a question.
Sure.
When you say members, I'm looking at like Christ Hospital and St. Elizabeth. Can somebody be, are they exclusive to one hospital or another, or can they be a member of both hospitals?
Well, so you're saying a member, like, can they be seen at St. E's, Florence, and all of a sudden at Fort Thomas, or can they be seen at the Christ and St. E's?
Yeah, I guess I'm looking for a definition of what that member, by a member, what does that mean?
So by your member is your employees and anybody covered under their plan. Now they can choose if they want to go to Christ or St. E's. We do kind of guide them, when they sign up, they really want to, we want to push them towards one or the other. I
Okay,
guess this is what I'm trying to say there. But I mean, they typically they can go where, where they would like. Does that answer your question?
yes, it does. Thank you.
Okay.
That just, Tony, that just means plan members. So
Yeah.
it doesn't really mean that they're belonging to one hospital system or another. Although on our plans 9, 10, and 11, we do ask people to pick a preferred hospital system, just because when you have a particular hospital ID on your card, when the claims ultimately get processed at that hospital system, we get a slightly better reimbursement rate as a plan. But people are free to go to whatever hospital or provider they want.
Very good.
All right. Okay, so we have done that. Let's look at our inpatient surgeries, page 10. All right, so I'm sorry, yeah, this is imaging and surgery utilization. You had 168 scans, which is great. We want our members to do that. You're going to see right here, St. E's Medical Center is where you've had 12 MRIs and 29 CTs. Total plan and member paid was about $28,000. Children's Hospital Medical Center, you had 9, 4 CTs. Obviously, we know that children's is always going to be a little bit higher, more of a specialized kind of visit is the assumption on there. St. E's grant, you're going to see that you had 16 CTs done there. You are above our benchmark as far as CT scans by about 24%. And total MRIs, you're up about 8%. Most common diagnosis was medical complications for your scanning, for your scans, and as far as your surgery utilization. You are going to see your tops. I got to scroll down. Sorry. Your St. E's medical, you've had 26 surgeries. Total plan and member paid about $228,000. Then you'll see your St. E's Fort Thomas and then your Children's there. Next page is just going to be your ER room utilization. And this is always good. Sometimes we can use this to educate members and employees as far as utilizing the ER, when they could have gone to their PCP or urgent care or something. But it looks like you guys run really well on your ER utilization. So you're going to see that you had 4 ER visits by severity. It was low, moderate. We would want to see members using the ER if it's a high or very high severity. You're going to see most of them were trauma and accidents. The most common avoidable diagnosis to go to the ER was a UTI. You did have 17% of your ER visits were potentially avoidable. Our benchmark is about 24%, so you're good there. You do have one member, we kind of call them frequent flyers. She or he, they, I don't know, had 6 or more ER visits. The member accounted for 6 visits out of all of your ER visits, about 3% of your total. And we can gather information on, why, maybe this member didn't have a primary care provider, something like that. So we can maybe do some education on that.
And we did check to see what those 6 visits were for, and it looks like a few of them were for kidney stones, which obviously, that's a legitimate use of the emergency room. And they had a migraine, upper respiratory infection, and headache. So looks like that member had a few things going on, but
I would say kidney stones. It's a valid ER
Are
visit.
you familiar with Kroger's Little Clinic? Cheaper,
Yeah.
avoidable.
Amber, if we could find out a little more about that member, maybe do some outreach, just make sure they have a primary care physician.
Yeah, absolutely. Yep,
I mean,
I'll dig into that and follow up with that.
Okay, thank you.
Sure. Then we'll touch base on your inpatient visits. Looks good here. You did have 26 admissions. 8 of them, or you're going to see you've got 4 were your average length of stay. I'm sorry, days medical, 4 days surgical. Maternity, you did have mental health inpatient. Average length of a stay was about 8 days. No substance abuse. 8% of your admissions were 30-day readmissions, which is great. You're below the benchmark. 35% of your admissions did originate from your ER visit. So that's great. I mean, if obviously we know they're utilizing the ER, they're admitted. We want them to, get the care that they need. Whoops, sorry about that. Any questions on this? Okay. Okay, so here we get into your shock claimant. These are the members that are causing your plan to run a little high. So if you look at the page below it, or I guess 2 pages below it, so page 15, we can compare this year to last year and see where our shock claimants are. You do have quite a few members that are over the threshold. So you're going to see that you've got about 23 shock claimants. And if we look at the list here, the top one here is turned off the plan. They were the high risk. There was about $40,000 or $400,000 in medical and RX paid claims. You can go through here and you can see you've got an active employee. You can see that they've got some embolism, some stuff going on there. It does look like the overall care alert score, and this is right here. And what we're looking at here as far as your care scores, we want this to go down as far, and also your risk score. So if we've got a member who seems to, let's say they have cancer, we know that score is going to continue to go up. Let's say they're going to continue on the plan, get treatment. You're going to see their score maybe go up, stay the same. We want to see a drop in the score. So the lower the numbers here, the better. So we do see that most of them are going down, which is great. That's exactly what we want to see. So you've got your concurrent risk score and your prospective risk. So if they were a 30, we want to see it at 27. Obviously, it's numbers term, but that's just an example. So you can see here, it looks like you had a snake bite on your plan. You've had, if you've got some lymphoma, some, shortness of breath, stuff like that. So these are members who are above your $45,000 or $42,500 threshold. So they hit that. They hit this high claimant report.
And Amber, if I could just make a couple of comments here. So this is kind of the real story from last year is your shock claims.
It is.
We had about $600,000 more in shock claims this year. Year we just had to compare it to the prior year. And that really drove your costs up. And as Amber mentioned, most of the risk scores are either improving or staying about the same. So that bodes well for this year. We did, of course, add a few new groups, so we don't, know fully what the picture is within those groups. But our underwriting, looked good as far as our new participants are concerned. So hopefully next year our shock claimant situation looks better.
So how's that threshold set, Amber?
So the threshold is set. So what we want is sort of the threshold for the current risk and prospective risk to go down, and it's based on, I think it's the 50% or more of the specific deductible. If they're hitting that, and if they're going to continue on with their treatment, that threshold is going to increase or go down based on what we're seeing as far as their claims coming in.
Does it vary year to year, the threshold amount?
It's based on your stop loss.
Right.
It's half of your specific deductible.
Mm-hmm.
Okay.
Yeah. So this report shows anybody at 50% or more of that.
I guess I'm looking at that number thinking prices are up all across the board for everything, does that shock us that the shock claimants are higher?
That's probably part of the equation.
Okay.
But yeah, you just have more serious conditions going on this past year.
Yeah, you really do. And again, that's like Lisa said, that's why your claims are up compared to last year. Okay, so any questions on this? Thanks, Lisa.
Sure.
Okay. Again, you can go down and you can compare it to right here, page 15, which is your previous year. All right, I'm going to hop on down to your top chronic conditions. You're going to see your top chronic condition remains hypertension. You've got 115 members currently being treated for it. Last year, previous period was 133, down from our benchmark, which is about 99. Hyperlipidemia, lower back pain still remains your top 3, down from last year. So that's great. They could be getting their, doing physical therapy or something like that. So that's great to see that come down. Sorry about that. You will see your asthma. Right here is your Care Alert score summary for chronic conditions. We want to make sure that members who have these conditions, asthma, COPD, diabetes, that they are being seen and they are being treated. So we do want to see these numbers go down. Obviously, your previous period, you had average about 18.53 members. Right now, you're at 14.94 members. So we want to make sure that members are being seen, and that looks like that's what's happening. You're below our benchmark. You've improved as far as members last year that were getting treatment for asthma. So we definitely want to see that go down, which means members are being seen and they're managing their condition.
I'm not seeing that bottom of that page you're talking about, Amber. You got that on your screen? Am I the only one not seeing the whole thing?
I've got it on page 17. Can everybody see that?
I can see the top lines, but I don't see the.
Oh, let me see. Okay, let me see if I can. Well, let me pop back up. Do you see it now? Can you see? Maybe
other brothers seeing it. I'm not seeing it. I only see the top. I see the benchmark, current, previous benchmark. I'm not seeing the care score. I can pull it up on my screen. It's okay.
I'm sorry about that. It's page 17, and I'm just looking at the little box here down at the bottom, which has like asthma, COPD, hyperlipidemia, stuff like that. So you're going to see the current period score as opposed to last year, and then below our benchmark.
Yeah, and those statistics really speak to the efficacy of your well living program. The fact that you're continuing to improve on the chronic disease score and that you're so far below the benchmark.
Yes.
Is really good news.
Yep. That means people are treating these conditions. So that's great. That's what we want. Let me go to page 18. Can you see that?
Yes.
Okay. Just to touch base a little bit more on what was just above here, your asthma. You did have, you've got 33 members being treated for asthma. You are going to see that a visit to the ER, ED, urgent care in the last 6 months. You've had about 3. This is just going to tell you the chronic conditions and the services. They've seen their provider. You've got great 32 members in the last 12 months have seen their provider for asthma. This will just tell you a little breakdown. COPD did have 1 member, had an ER visit. So it does look like people are managing their chronic conditions. You've got diabetes, you've got the annual dilated eye exam. We could probably bump that up a little bit, make sure people are following up with, with their eye exams and their diabetes. So this is just a page to kind of break that down. You can see what people are doing in order to treat these chronic conditions. And sorry about that. I am going to, right here is your well living. And this may have been added to your packet. You may not have this page, but I can definitely get you a copy of this. This is going to tell you your compliance report. This was as of 8/7. So it usually runs about a week or so behind as far as the reporting. You're going to see that your non-compliant is in the red here for your annual wellness. You're running about 50% for compliancy there. Cholesterol, people are getting their screenings, looks good. Colonoscopies, we definitely do want to, make sure everyone's getting those. Your mammograms and your PAPs for 21 to 29, and then anyone over 30. This is going to tell you your 1 year look back. You had 237 compliant for your annual wellness and 229 non-compliant. So this gives you just a little bit of a year look back as far as cholesterol mammogram. So again, we want to make sure that people are getting their wellness exams. I know that that's important to you guys. So anything we can do to kind of encourage people, we definitely want to do that.
And Amber, so this report was run on 8/7, and the cutoff date for compliance is, I believe, April 30th. Is that right?
That's
so if we were looking at this report as of April the 30th, it would look a lot better, especially on the annual wellness.
Yeah.
So I wouldn't get too worked up about half of the people not having their annual wellness exam yet, because as the year progresses and we get closer to the deadline, that those percentages will go up a lot.
Yeah. And you'll see that in your claims that we went over above. You'll see, a spike in the claims early in the year because people know that their wellness is due. So, all right. I'm going to go down to your RX summary, and we'll just kind of touch base on this. So again, we've talked about excluding your specialty medications and how it does affect your plan, which is great. So you do have 85.65% of your prescriptions are generic. And that's exactly what we look for. We want to make sure that we're pushing the generics, that we're offering those to members, that they know that the coverage is there for the generics. You do have about and you have about 1,066 brands. Those are probably members or especially medications that we couldn't, maybe outsource. So that does hit your, hit your plan. The patients paid about $81,000 for medications. Coupons you can see, and like Lisa touch base on the RX refunds. You do have $80,000 here in coupons. So that's great. Total cost for your plan so far is $886,691 on your total cost for members and plans as far as your prescription. So again, we do definitely want to have the generic medications pushed out there to the members as much as we can. It saves the plan, saves the members. Next page, we can just look at this real quick. This is just going to tell you your RX count last year as opposed to this year. RX count last year, about 8,200. You're down significantly, about 7,400. Your RX count, you can tell your membership. Obviously, that's down a little bit. Your patients paid as far as and then compared to what the plan paid. So this will just give you your generic dispensing amount is about 85%. Last year, about 85.65 this year. So we want to just keep seeing that number, that generic go up. And the next page is going to give you your top plan paid for medications. You've got Ozempic. Ozempic, now keep in mind, there is in place, the Ozempic cannot be used for the weight loss benefit. So in order to meet the criteria for Ozempic, you do have to have a diagnosis of diabetes. So you do have 79 prescriptions for diabetes on this one. And you will see your plans paid about $125,000 for that. Eliquis, Jardiance, again, you're going to see these specialty brand names. Anytime you see these medications or there's a commercial for it, that those are high cost medications. Solera, that is also an expensive medication, about $27,000 so far, and you've got 2 prescriptions for that. So this just shares a little bit of where your RX cost is. And this right here just tells you, the next page is just going to tell you your what are they being used for? Why is this medication here? And so you've got insulin, you've got your diabetic supplies, steroids. You can go down here and kind of see what these medications are being used for. And then the last page here is going to be your top utilized pharmacies. You're going to see you've got Sam's, you've got a Kroger pharmacy here. That seems to be your highest with 753 prescriptions. You can see that you've got Sam's Pharmacy as well, with your patient paid, your plan paid. So this is going to tell you your plan paid right here and average cost of medication. Sam's utilized, you've got 169 prescriptions there. You've got 8 patients utilizing it. So that's probably more of a specialty or a brand medication that maybe Kroger, or it could be, you know, your mail order or something that's coming from them. And that wraps up my end of the reporting. Is there any questions on that?
So I have a quick question about the brands. And you indicated that our generic utilization is relatively high and I guess where we need it to be, but I don't want to assume, but I would have to assume that if, you know, if there's a brand and a generic, does it default to the generic, or is the majority of the brand the cost for the plan is that there is not a generic
That is correct.
alternative?
So most of the time, when the doctor writes a prescription, it's going to have dispensed as written or generic. Most of the time, it's always going to default to the generic, unless there's not, like you said, a generic available for that. So that's why you're going to see those medications. You know, maybe they've tried a couple generic things, not the equivalent to the brand, and it just didn't work for them. So the next step is something a little bit more expensive, a little bit, you know, a little bit different of a medication. But now typically there's not a generic for those more expensive medications, unfortunately.
Yeah, you are above the optimal level of generic dispensation. We would consider 85% and higher than that to be optimal. So you're doing well. We do have a few groups who have more than a 90% generic dispensation rate. But you do still have a lot of people on flat dollar copays because you have the RX option A, I think we call it, where you can stick flat dollar generics. And that tends to be less of an incentive when you have flat dollar brand copays for people to gravitate toward generics. So we could probably bump that up some if we had everybody on RXB.
Yeah. All right. Is there any questions on that report?
Yeah, I thought it was interesting that Ozempic by itself, even for diabetic use, it represents 20% of our brand spend.
It does.
Yeah. And
I know.
I don't know, is there an alternative to that as far as for treating diabetes?
So in order to actually get the Ozempic, the members have gone through a step program therapy where they've tried maybe metformin, a few of the other medications, and they're just not seeing the results. Ozempic, you have to have an A1C of 7% or higher for a certain amount of time after I've tried, while trying different medications. So for the most part, they've tried the medications that, you know, would save the plan, save the members money, but they're not responding to that treatment. So then they move to the next level.
Just had to ask.
I know. All right. Thanks, everyone.
And if I could, I put in the chat the recommended reserve amounts for fiscal 25. And the minimum amount of reserve that we would recommend is 575,000. Adequate is about 980,000, and optimal is 2.1 million. So you're at almost twice the adequate level and pretty close to optimal, but not quite there. So any questions or comments on that?
So just kind of an overview.
Go ahead, Paul.
Oh, sorry. So just as far as the care alert score and things, I mean, we've had a tremendous amount of those shock claimants, but I mean, I guess if I'm understanding correctly, that next year, again, there's no guarantee, but we're seeing a trend away from that. You know, the care alert scores are relatively low, so we're trending towards, you know, hopefully a better year for next year. Like we're doing just about everything that we could possibly be doing. I mean, we've carved out our specialty drugs, and you know, as far as the premium increase for next year, again, we're on track to kind of continue with a trend up. Is that correct?
Yes. Yes, very well stated, Paul. Yes, it looks like the risk profile is improving, and we are funding the plan at a greater level next year. So I think you're in good shape.
Okay.
Yeah,
Thank you.
I also, when I saw the shock claimants, I mean, the first shock claimant, just being $400,000 by themselves, I was like, well, that explains this year.
Yeah.
And
It really does.
so next year, or this current year that we're in, it's a different ball game. So,
Yeah. Yeah,
I'm
and keep in mind that top shot claimant is termed from the plan. So if they are carrying on treatment or what have you, it's not going to hit the plan.
I have a question on the
Any
prescription and different pharmacies. Isn't Walgreens normally, as a rule of thumb, higher than everybody else?
Yes.
Yep. They're not the best value pharmacy. They don't accept the acquisition cost index pricing that your plan uses, that all the other pharmacies accept. And just to kind of put this on your radar, it doesn't affect your plan until next year, July the 1st of 2025. But the state of Kentucky has some new mandates that they passed. And one of those prohibits plans from steering people away from a particular pharmacy. So we are going to have to do something with our Walgreens steerage. Yeah, unless you want to just, be out of compliance with the state mandate, which we usually don't recommend you do. But we've had that situation with groups in Tennessee because the state of Tennessee had a similar mandate a couple of years ago, and we had groups who were trying to steer people away from Walgreens. And what ended up happening, at least so far, is that people still haven't moved back to Walgreens. I think they were just used to not using Walgreens, and so we just didn't make a big deal out of the fact that now you can go to Walgreens for the same copays, and we didn't see a lot of utilization change.
Good news in Carrollton, as far as insurance goes, our Walgreens is closing.
Yay.
That's perfect. That works.
Yeah, I mean, that's one way, right?
Yeah.
While we don't want
Walgreens is closing a lot of their retail stores, so that we'll probably see more of that.
They've had a rough 2 years.
Mm-hmm.
My wife had worked there for 15 years and left 2 years ago to go St. E's. So, they had a lot of different issues. But I was going to ask too: can we just exclude them as an option from or do we have to kind of leave everyone up? Just like we can't, you can't necessarily every hospital is not network. Why is every pharmacy in network?
Right. Yeah, we used to be able to exclude them, but under this new mandate, our interpretation is that you cannot exclude them.
Why should we exclude them? Just like, hey, you can go to Christ, but it's out of network. Tough. And it's not just because, obviously Christ is more expensive because our preferred, carrier is St. E's. So I guess I'm just trying to understand, just trying to get that
Yeah.
reason. And I
Because there's not a state mandate prohibiting you from doing that with hospitals, but they've specifically addressed the pharmacy issue. So, yeah.
So the one that's closing here in Carrollton is apparently, so they say, a maintenance issue with the building. The company that owns, because they rent, lease. The company that owns the building won't repair the building now. I don't really know why they're going out. It doesn't matter. It's just that they're going out. And I'm out of the 400 and some members, I think it is that we have. That Carrollton has about 70 of those between the utilities and the city side here. So with that said, I'm not sure how many of the 70 use Walgreens, but I'm sure there's a handful. And while we don't want to lose a business here, that does help the insurance a little bit for anybody here in town that does use it. So
maybe we take the opportunity when we have to revisit that to take a good hard look at the pharmacy plan A's tier splits, and instead of lowering Walgreens down, maybe we look at taking everybody else up. I don't know, particularly with our pharmacy being where it is. This is, maybe a point of discussion just to at least talk about that and kind of see where we go. Any other discussion on the great amount of data we just received in the year-end review? Okay.
I do have a comment about the Walgreens. If we exclude them, which I guess I don't think we can do, but I just had this happen over the weekend. I had an ear infection, and the only pharmacy that was open in the entire tri-state area was Walgreens in Florence. So either I would have had to wait till Monday morning, or I could get my medication on Thursday or on Sunday night. So just something to consider, that most pharmacies have cut their hours. And if you need something after hours, it's actually the only option.
The only 24-hour pharmacy in Northern Kentucky, and it's been that way going back almost 8 years, is that one out on Mall Road. And I just happen to do that because my wife's a pharmacist where she started working. So and that's been a struggle for them to keep that open because they're robbed so frequently.
Right.
I'm surprised it's still run because I know they killed it and then brought it back and then basically told the state they were going to keep it and then weren't staying in compliance. So they've been forced to kind of stay 24 hours because that's been something they've been trying to kill, I know, for 2 years.
Right. So just a thought on, because I personally don't want to go to Walgreens either, but I had no choice that
yeah, it's a great point, Lindy. And that's historically why most of our groups have not outright excluded Walgreens, just because, if you need something in the middle of the night, you had no other options.
Right.
All right. Any other comments? Hearing none, next item on the agenda is the benefit management agreement for this fiscal year.
Yeah, so this is MedBen's contract for next year, which we have reviewed. We made sure that all of the terms within it were in alignment with what was presented at the renewal. And they did present a full agreement this year instead of just a new fee schedule. And we read through it, and it looks okay to us. I don't know if anybody's got any questions or concerns about it, but we would recommend that you approve that.
Any questions or comments?
Nope, but I trust Lisa and Mike and their crew enough that if they recommend it, I'll make that motion if that's what you're needing.
Thank you, Mayor.
Mayor Adams made a motion. Is there a second?
I'll second.
All right, second, Paul. Any other discussion? Hearing none, all in favor, please say aye. 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 Any opposed? All right, I'll go ahead and sign this and get this scanned in.
Thank you.
Next item on the agenda is the monthly billing, the review of the process. We have a couple new members, and so this would be a nice time to review all this because we're also going to have a banking change here in a second. So we'll go ahead and start on that.
Okay, can you hear me okay?
Yes.
Yep, okay. Hi, I'm Michelle Mittendorf with Cheryl Morgan, and I take care of all the billing for the group. So like Craig said, we just kind of wanted to do an overview, especially since we have new members. So how this works is MedBen sends me the detail with all the people listed first. And then from that, I prepare the monthly invoice, kind of a summary that I then send to each group. And once I send it, I tell MedBen, okay, you can release the detail to their secure accounts. So then at that point, whoever is receiving a bill should go out to the MedBen secure account and check the bill. And especially if they've had any additions or deletions for the month, it's a great opportunity to see if those happened correctly. And if those did not happen correctly, please let us know so that we can get it adjusted. Now, the tricky thing is if you do have a correction for the month, we ask that you go ahead and pay it as is, and the adjustment will come through on the next month in order to keep our records in sync with MedBen's. So then once you're happy with it and you make your payment, if you could just take the summary I send you and sign off on it and date it so that I know that payment has been made. Then I'll keep a record of that. And then you're done for the month. So that's kind of how it works. And we just thought we should probably review that with everybody once in a while because new people come in and they might not understand it all. So are there any questions about that?
Yeah, but if an entity wanted multiple staff members to get access to that email or get access to that secure portal form, they could set that up, correct?
Yeah, yep. And it's just really important that somebody at the group is looking at it every month, because if nobody's looking at it, somebody could be on or off incorrectly, and it would just continue every month. So a lot of groups have no change any month. So, as long as there's no change, they could just say, yep, same amount, send it in, no problem. But particularly in months where you do have changes is when I would really encourage you to catch it, because going forward, it could stay on there month after month incorrectly because we don't audit each account. I mean, I do an overview, but I don't know specifically, this person should be on, this person should be off. I just kind of do the overview. So we would really encourage all the groups to look at the bills, especially on months where there's changes, so that we can catch any problems up front so that they don't go on and on and on each month.
Great. Any questions? All right. Hearing none, the item we added to the agenda is the banking transition. So we are now to the point where we can start asking MedBin to start making the check runs out of the Heritage Bank account instead of the Fifth Third account. If you'll remember, earlier in 2024, the board approved making that change to Heritage from Fifth Third. And thanks to the ad district and the two Chris's, we are now set up with Heritage Bank's new Positive Pay system, which is a fraud prevention system, where there you will be getting an upload from one of us from information we get from MedBin on all of the check numbers and the payees and the check amounts, and then they double check those against that before they clear the checks. And so the thing that needs to change is all of us have been depositing our monthly premiums into the Fifth Third account. I'm now going to ask, starting with the upcoming month, that your next payment to start making those payments to the Heritage Bank account, and I'll work with MedBin to get the routing number and the account number listed through the secure email from MedBin so that you can see that. And then MedBin will start issuing those checks out of that new account. And then we'll let the Fifth Third account drain out and with the checks that have already been cleared. And then once we stop clearing those checks, and again, all those checks have the 6 month move, we'll take the balance and we'll move that over. So right now we have two bank accounts, one at Heritage, one at Fifth Third, and both of them have about $1 million in them. So, so we should be able to. We've been cash flowing the Fifth Third account with the $1 million in it since we set up the new account with Heritage, and so I'm confident we can cash flow the Heritage account as long as we start putting premiums into it, and then we'll be able to clear the Fifth Third account. So that's the most important part of what needs to happen regarding the banking. And so please let anybody in your agency who is in charge of making that payment know so we can get that transition to occur. The second thing is right now on the Heritage Bank account, myself and Harry are the two signers. I think we need to add Chris Corba from the ad district to that as an actual authorized signer. Because in the past, we've always had somebody from the ad district on, and quite frankly, they do our administrative work. So I would entertain a motion to add Chris Corba to the Heritage Bank account as a signer. Okay, I see Mayor Adams' hand.
I'll second.
Second.
All right, great. Second. Any other discussion on that motion?
I
Oh,
apologize
Terry?
if I missed this. but the deposits are going to start going into Heritage effective when?
Next pay if you can. Next time you pay if you can.
Okay, so we have some deposit now, so we won't take them to Fifth Third. We'll take them straight to Heritage.
Right. Let us get you those account numbers though. But yes.
Oh yeah, of course. Okay.
Yes.
Thank
Okay.
you.
Thank you. Terry.
Oh, I'm sorry.
Sorry, I'm trying to get my phone to quit ringing. My quick question on Chris. Do we do that? Chris, does Chris have a title, or do we do it specifically to the person? You know, because there's been, I know, no offense to the ad, but there's been a little turnover over at the ad lately, right? So do we appoint the position person, or do we have to actually appoint actual person?
The bank would like the person's name.
Okay, all right, that's fine. Just want to make sure.
Okay,
And
Lindy.
Terry, we've historically had the finance director, which was Lance Henshaw for the last 2 years.
Right.
There was an opportunity for him to move back home and take the directorship of the ad in his local area. So I go, we'll have that support for you. And that too, I go, us finance, or at least my position, we're bonded for that reason.
Yeah, okay.
The ad's covered. I will double check if that extends to the insurance board as well, but they go, that's historically the reason why it's the person that has this finance directorship position.
And I get that we have to have a name for the bank. I was just asking that question.
Okay.
All right, thanks, Chris.
Lindy.
Help.
It was just another question about those deposits because we cut a check yesterday and we're going to take it to the bank today. Should I hold off until we get that banking information to deposit to Heritage?
Yeah, if you don't mind, just because we're going to start cutting checks out of that probably next week.
Okay.
If something goes into Fifth Third account, we can get it over to Heritage if we have to. I just try not to do that because I have to walk in and ask for a counter check and then have to walk it over to Heritage. And I try not to do things that make their fraud prevention office nervous. So
Did you say that was going to come from MedBin Secure with the routing and banking?
I'm going to ask MedBin to send it through the MedBin Security. I think that's the best way to do it than just send out a blank email from all of us.
Correct.
Thank you.
And then the last thing on that is the chances are pretty good that we are going to have a balance left in the Fifth Third account after everything clears. Right now, the Heritage account has given us 2.5% interest, which is a permanent interest rate. It's not going to fluctuate with the Federal Reserve. So that's what we're getting. But we right now have an opportunity to go get certificates of deposit, particularly at Fifth Third, for anywhere from 4.25% for like a year to 4.5% for like 3 months. How does everybody feel about me kicking the tires on that with Fifth Third and maybe taking no more than $250,000 because that's the FDIC limit. And once you cross over that limit, they get a little squirrely on having to do collateralization for government accounts. Taking that and just setting it into a short-term CD while we go through this closeout process.
Mr. Chairman, we still have a motion on the floor for
okay. Thank you.
To be
I appreciate that. Okay, so motion on adding Chris Corba as the signer to the Heritage Bank account. All in favor, please say aye. Aye. Any opposed? Okay, great. Thank you, Mr. Courtney, for keeping me on track. Now back to the short-term CD question. Do you all want to mess with that, or you just want to let it sit?
I gotta assume all of our money, regardless of what county it's in and where it is, it's all pledged, though, right? All of our money is pledged.
All of our money is currently pledged. But if we move it into another checking account, it's easier for the bank because if we took so the $1 million we have at Heritage is pledged. If we take $250,000 out and put it into a new account, then Heritage only has to pledge $750,000 of it because the other $250,000 in the other account's covered by FDIC.
And when you say short term, what's the term you're thinking?
Right now, the best interest rates are like 3 months. The next best interest rate's like 6 months. So something short because I'm not holding on to this Fifth Third account after all the checks clear and everything goes. We're going to leave Fifth Third. We're not going to leave that account open.
and tying that money up in a CD even for 3 or 6 months, it's not money that we're gonna need before then, right?
I'm sorry, I really couldn't hear you.
Hey, Craig, he said if we tie it up in CD, it's not money we're going to need in the next 3 to 6 months. And
Oh, no, I don't think so.
if we're making that banking change here in mid-August and any checks that have been cut, you've got about a 60 or a 6 month, 180 day. So, the longest of this Fifth Third account will remain open is probably to the end of February of next year, because that would give all those checks that lifespan to kind of run their course. If they're going to get cashed, they were going to get cashed. So I go, it's essentially, since we've got money to park anyway, hey, just making sure we're being good fiduciaries with that money in the 6 month where we see an opportunity to get a little better interest rate for money that's going to be sitting idle in the meantime anyway.
I don't see an issue with it.
I think it's a nice suggestion, Craig. Good work.
Right. And if there's no other discussions or anything, because the bank's going to want to see this in minutes, I'll take a motion to authorize me as the chair to move no more than $250,000 into a CD of 6 months or less at Fifth Third.
I'll make that motion, Craig.
Thank you.
I'll second.
And Terry raises his hand a second. All right. Any other discussion? Hearing none, all in favor, please say aye. Aye.
Aye.
Any opposed? All right. Thank you. That's all I have under agenda items. Are there any announcements or reminders, such as when is our next meeting?
On that, in the meantime, we'll plug our conference, which is September 17th and 18th. Everybody should have gotten an invitation, but if you did not, let us know and we'll get one over to you. Next meeting is October 18th at 9:00.
One thing I did want to mention is we want to mention welcome Brandy from the city of Southgate is on this call. The two new other members, Crescentville Fire and Warsaw, I spoke to them. They are going to be joining us at the next meeting. But Brandy was able to jump on and heard some of this, so hopefully her head isn't spinning too much. They're all as fun as this meeting, Brandy.
Anything else for the good of the order? All right. Hearing none, I'll entertain the motion to adjourn.
Second.
Who was the first?
I make the motion to adjourn.
There you go. Terry second. All right, cool. All right. All in favor, please say aye. Aye. Any opposed? All right. See you all in October, if not at the conference.
Thanks, everybody.